All right, guys, Ken and Omertag, reproductive endocrine infertility. This is the second part of the infertility module. This is the second lesson of the fertility treatment volume. So we're going to be talking about assisted reproductive technology. Previously, we talked about ovulation, induction, and superovulation using oral agents and non-assisted reproductive technologies. Now we're going to talk about assisted reproductive technology. Specifically, we're going to talk about in vitro fertilization, plus or minus the use of ICSI, which is an insemination strategy called intracytoplasmic sperm injection. And then we're also going to talk about pre-implantation genetic testing. So there's a lot of stuff to digest here. We're going to go through it slowly and deliberately. The third part of this module will be third-party reproduction, and we'll be putting it all together. Again, the reason we're talking about these things is because assisted reproductive technologies essentially builds on your understanding of the menstrual cycle. So it always comes back to that. So again, remember what we're talking about when we talk about fertility treatment. We're talking about ovulation, induction, and superovulation is usually the goal. And the goal of these treatments are ultimately to manipulate and or amplify the HPO axis. Well, when we're doing assisted reproductive technology, specifically IVF, our goal is to manipulate and amplify the response. So what we're trying to do is we're trying to manipulate the HPO axis so that we can get all of these follicles to be recruited. Instead of 1, 2, or 3, we want to try to recruit as many as are available. So the point here, and that's why I emphasize this, is to amplify the HPO axis. That is the goal with in vitro fertilization. Now, there are certain clinical circumstances where, patients 42 years old and amplification is only going to get you 3 follicles. But the efficiency of IVF, or I should say this way, IVF is a window into the inefficiencies of human reproduction. And in order to maximize the likelihood of live birth in a given cycle, it makes sense to try to superovulate patients with IVF in a controlled manner so that we can get as many eggs as possible, to inseminate as many eggs as possible, to then fertilize those eggs and then grow them out in culture. Because we know that at baseline, when someone gets 20 eggs, that does not mean they have 20 live births, because human reproduction is very inefficient and there is a lot of attrition along the way, as I'll point out. So let's keep building here. So let's talk about how IVF works. So basically, it's an overview. And in vitro fertilization, it takes principles from what we learned earlier about ovulation, induction, and specifically superovulation, and just magnifies them and specifically amplifies them. So what we do with IVF is essentially we're using FSH and LH to optimize the maximum recruitment of the cohort of follicles. So instead of you can use Clomid to do IVF, but for the purposes of this, we're going to focus on using gonadotropins because that's how generally IVF is practiced, is you would use exogenous FSH and LH, like we talked about previously, to try to get all of these eggs to grow. And then you would use an agent to prevent ovulation. So you would need an agent to prevent ovulation. So that would be like a GnRH analog, whether it's an agonist or antagonist. Okay. And then it requires a surgical procedure to then go in and retrieve the eggs. So it requires a surgical procedure to retrieve eggs. And then it requires insemination of those eggs, and then fertilization. And then number 5 here would be culture and transfer of embryos. Okay, so there are 5 large components to how IVF works. We're going to dive into this a lot deeper here, but I wanted to kind of give you an overview of how this works. Okay, so I'm going to erase this and I'm going to write it a little bit more cleanly. Okay, so what's going to happen is the first thing you got to do is you got to stimulate the ovaries. You have to prevent ovulation, because if you don't prevent ovulation, then the patient will ovulate before you have a chance to retrieve the eggs. So that is not good. And in the early days of IVF, that's actually what would happen. So early 80s, when they were stimulating using FSH and LH, Remember, they didn't have transvaginal ultrasound until 1986, 87. So in the early 80s, when they were doing IVF, they were using rudimentary LH assays, and they would just go in with laparoscopy and think that, okay, I think the patient is close. Let's scope them and try to remove the follicle that's there 2 or 3. So it wasn't until we had analogs available to prevent ovulation, which came in the late 80s with the GnRH agonist, and then in the late 90s with the GnRH antagonist, that we were able to reliably prevent ovulation from occurring, and canceling cycles due to premature ovulation essentially went by the wayside. So these drugs have essentially modernized the approach to IVF, and we've not really had these since the late 80s. So IVF in its current form is really only, even though the first IVF live birth was 1978, IVF in its current form didn't really start being practiced until the late 80s, early 90s. So the other thing is you have to, like we said, you have to retrieve the egg. So you have to do a surgical retrieval. This is typically an outpatient procedure. Usually takes 20 minutes. It's done under sedation. And it's basically a vaginal ultrasound in which a vaginal ultrasound probe goes through the vagina. I'll show you what that looks like. You can see my fashion sense here. So with an egg retrieval, you can see there's this vaginal ultrasound probe. It goes in the vagina, and there's a special needle that's attached to it, and that needle goes into the vagina, through the vagina into the ovary. Now, if you think about it, an ovary that's unstimulated is maybe about 2 centimeters. An ovary that is stimulated can be 8 to 10 centimeters. So these ovaries are usually resting just posterior and behind the vagina, so they're easily accessible vaginally. That same day that the egg retrieval is performed, the sperm is collected and insemination is the eggs are inseminated. So we have insemination, which is the act of putting the sperm around the egg. And so you can do that conventionally, which is where you just drop 100,000 sperm around an egg and see which one fertilizes. Or you can do ICSI, which is where you take one sperm and inject it directly into the egg. ICSI is usually reserved for male factor infertility, where the sperm counts are low. There are some other indications for ICSI as well, but male factor is the primary one, and ICSI did not become available until 1992. So moving forward, then the final thing is embryo culture and ultimately embryo transfer, which I'll abbreviate ET, embryo transfer. And that's the act of putting the embryo into the uterine cavity. And again, we can see that here pretty easily. So take your pick here. I like this one. I like these graphics. So you can see there's a little catheter that has the embryos in it, and those embryos are deposited into the uterine cavity about 15 millimeters away from the back of the uterus under ultrasound guidance while the woman is awake. This takes 5 minutes. It's a pap smear. It doesn't take very long. So let's go over this in a little bit more detail. So we've kind of hit on the overview. Now it's important to kind of look at it in some detail. So this is kind of based on the talk that I give to all of the patients that I see. So what you're hearing is similar to what I explain to the patients when they come in to have a consultation with me about IVF. I will spend a little more time with definitions than I typically do with a patient, just because of the nature of the course and the learning points to try to take home. So it's pretty close, but not completely the same. So how does IVF work? Well, first of all, and I'm going to be pretty practical here, the patient has to first financially and medically clear. And I'll talk a little bit about what that entails. But these things have to happen first, and they kind of happen in tandem. But once the patient medically and financially clears, then with the start of cycle day number 1, they start birth control pills. Now, this is one particular protocol that I'm describing. This is kind of like the original, kind of the most commonly used protocol. Just to kind of give you a sense, there are lots of different protocols, but I'm just going to keep it simple here, for the sake of this exercise. So we start birth control pills, and that's usually for 21 days. And we usually start those on cycle day 2 to 4. While the patient is on birth control pills, we then will give them their first injection of Lupron. So let's back up. Why are they on birth control pills? Well, first of all, they're on birth control pills because many of these patients will have irregular periods. So we give them birth control pills to help regulate their cycles. This is important because A, it gives them cycle predictability so that they know when they're coming in for monitoring. They know when their cycle is going to start, and they can plan their work schedule, their life schedule much more easily. Secondly, the birth control pills act to synchronize the cohort of follicles so that when we do stimulate the eggs, with the exogenous hormones, we are stimulating them ideally in sync, not desynchronously. So that's important because you want the cohort to kind of grow together, and you don't want part of the cohort to be out in front of the other. And birth control pills are thought to be able to help with that. So those are the two reasons why we typically give birth control pills. Better for the patient and honestly for the clinic. You can program patients to avoid procedures on weekends for staffing reasons, and then also to keep in mind that many IVF centers don't do IVF cycles 7 days a week every day like we do. Many of them do them in batches where they'll every 3 months they'll run, 40 people will go through an IVF cycle. So you need those birth control pills to help regulate the schedule and regulate people's cycles. That has not been shown to be a detriment. And then again, the synchronicity. Okay, so about 15 to 17 days into their birth control pill, they're going to start their Lupron injection. Lupron is a GnRH agonist, and the reason they start this is so that they can downregulate the gonadotropin receptors. So you want the Lupron downregulation because this tool will ultimately act to reduce or to eliminate the risk of premature ovulation. So we actually start it in the luteal phase of the prior cycle. So the patient starts it and then stops after the 21 days of the birth control pill pack. They'll stop their pills, they'll have a period, and we'll have new cycle day 1, of the next cycle. They'll come in for an ultrasound and blood test to make sure, A, their ultrasound should show a thin uterine lining, right? Because they just came off of a period. And then their estrogen levels should be low because they should not have any follicles because A, they've been on birth control pills, and B, they've been on Lupron and should be suppressed. So they should not be doing anything endogenously. So we want to confirm that everything is quiet. If everything looks good, then we will continue the Lupron at the current dose. Sometimes we adjust the dose depending on their antral follicle count, which is a marker of their ovarian reserve. If they have a low antral follicle count, we'll probably drop their Lupron so they're not as suppressed. Ultimately, though, we usually keep it the same, and then we start the other meds, the FSH and the LH injection. Now, typically, when I say the LH injection, I'm talking about human menopausal gonadotropins. So we usually do a combination of both where they get recombinant FSH and HMG. Now, this is just how we do it. There are some slight variations from clinic to clinic, but this usually starts on a Friday where they start these drugs. So we program them so they come in on a Wednesday, Thursday, or Friday, and then that Friday they start their drug. So they start their drug and then they come back on Monday, Wednesday, Friday, Saturday, and then the following Monday for monitoring. So this is usually about 10 days, okay? So they're coming in for estrogen levels because we want to see if their estrogen level is rising. Because if you're giving someone exogenous FSH, it should be stimulating their ovarian follicles, and as a result, their estradiol should start to go up. And then later in the cycle, we'll start to do more ultrasounds with the estrogen level. So on Friday and Saturday, we start doing ultrasounds with the estradiol level. And then and then all the way out to Monday, the same thing, to see now as the cycle progresses, their follicles should be starting to grow. Once their follicles reach a certain size, and that's usually when they have lead follicles that are 18 to 22 millimeters in size, then we'll typically give them their trigger injection. So their trigger shot is an HCG trigger that, again, looks like, it's usually a urinary product, that looks like LH. 36 to 48 hours later, we'll do the egg retrieval. Now, if they should not, the reason we give the HCG is not because we want them to ovulate, but it's because we want meiosis to resume. Remember, we talked about that previously. The LH surge is critical because it, helps set up the process for ovulation, gets down, the metalloproteinases start to break down the follicle so that the follicle ultimately will be released mechanically. But more important, that LH surge precipitates the events that result in the resumption of meiosis and the kicking off of the polar body, which is necessary for fertilization to occur. So the HCG trigger, that's why we're interested in the HCG trigger. We need to mature the eggs. So 36 hours after the HCG trigger shot, then we'll do what's called an egg retrieval, which we talked about earlier. Again, the patient is asleep under anesthesia. Looks like this. Pretty straightforward, vaginal ultrasound probe, and we aspirate all the follicles. We then take the eggs that we get, and then we'll do conventional insemination or ICSI. Now, again, ICSI is usually for male factor. If you're dealing with frozen eggs, if you're doing PGT, or if you've had prior failed fertilization. In a lot of cases, we'll do like an unexplained infertility. We'll do a split insemination where we'll do half of the eggs conventionally and half ICSI. And that can be a diagnostic as well as therapeutic application of ICSI. So if you had poor fertilization with the conventional group, but good fertilization with the ICSI group, that's great. You could tell the patient, the upside of that is you can tell the patient, hey, it looks like we kind of know what's going on here. There's a sperm-egg interaction problem. The downside of that approach is, well, you subjected half the eggs to an inferior treatment. Obviously, you didn't know that until after the fact. As a result, some people will use that as a justification to do ICSI on everybody. And when we look back epidemiologically, we've noticed that there are many clinics, like the national average of using ICSI is about 65%. There are many clinics who 99% of their cases involve ICSI. That's not because 99% of their cases have a male factor. It's because they just do ICSI on everybody. So let's move on. So the next day we find out how many embryos we have, specifically pre-embryos, and that's called OR zygote. So at the zygote OR 2PN. So you have 2 pronuclei the next day, the day after fertilization, or the day after insemination. You'll look and see what you have fertilization-wise. So you have 1 pronuclei from mom, 1 pronuclei from the sperm source. So if you want to see what that looks like, so you can see here a classic example. The best picture, I like this one the best. So here you can see, this is a zygote right here. You see 1 pronuclei right there, and then the other pronuclei next to it. You see a polar body kicked off. And then we're going to use this picture to kind of refer to the embryo development moving forward. So the next day, we'll find out, like I said, the day after insemination, this is day 1. We'll see how many zygotes we have. And then we'll look at the embryos again on day 3. On day 3, you would expect to see certain features. This is called a cleavage stage embryo. So what's happening is the embryo is the cells are beginning to cleave. So you like to see 6 to 10 cells. You like to see less than 15% fragmentation. And then you like to see symmetry. So these are the features that you're looking for on day 3. Now these features are, at this point the embryo is still relying on the maternal genome. It hasn't activated its own genome. But at this point, you have a better sense of which of those zygotes are growing appropriately. Because if they're hitting these marks here, 6 to 10 cells, these cells are symmetric, and there's less than 15% fragmentation of the cytoplasm, those are features that are more favorable for implantation. So here we have a day 3 embryo. It's actually better, I think. We have a day 3 embryo, and you can see these cells right here. They actually look symmetric. And remember, this is a 3-dimensional object under a 2-dimensional piece of paper, essentially. And you can see there's 1 cell here, 1 here, 1. So there's 1, 2, 3, 4, 5. And then there's 1 back here, 6. So it looks like a 6-cell embryo. And when you zoom in and out, you can see depth. The next, here is where you'll get variation from clinic to clinic. In our program, if the patient has 4 or more good-looking embryos on the 3rd day, it's hard for us to select the best embryo. So we'll grow the embryos out longer in culture until we get to the blastocyst stage. That's day 5. Okay. This structure here is called the inner cell mass. These structures out here are called the trophectoderm, or TE. These cells ultimately, the inner cell mass becomes the baby, and then the TE becomes the placenta. Okay, so TE becomes inner cell mass, becomes the baby and the fetus ultimately, and the trophectoderm cells become the placenta, and then you have this blastocele fluid in here. Okay. So at this stage, we usually recommend transferring one embryo. Okay. So the embryo that's transferred, again, we now bring the patient in and we do the embryo transfer like we showed here. And here, this picture actually shows cleavage stage embryos being transferred. But in the scenario that I'm describing, we would transfer one blastocyst into the uterus using this exact same technique. Now, how do we know that the endometrium is receptive? That's a great question. So when the patient does their egg retrieval, the other thing they have to do is start taking progesterone. So if you remember back in the menstrual cycle physiology, in a normal menstrual cycle, what happens after ovulation? Well, a corpus luteum eventually evolves and start making progesterone. And that progesterone helps transform a proliferative endometrium into a secretory endometrium. And that secretory endometrium is necessary for implantation to occur. The implantation window is the window in which the endometrium is maximally receptive to the day 5 embryo. So if you remember, actually, we didn't actually talk, I don't think if it should be noted, let me say it that way, that when the embryo is at the day 3 stage, it is still in the tube transiting in a normal, in a normal spontaneous pregnancy. A day 3 embryo is still in the tube. It's not until the 5th day that it arrives into the uterine cavity. So the progesterone exposure to the endometrium should match or be synchronized to the day of the embryo. It's not perfect, but the reality here is this patient is getting supplemented with progesterone to help support the endometrium so that it's gotten the appropriate amount of progesterone exposure so that when the embryo is placed into the uterine cavity, the embryo is in an environment where it would be receptive. Okay, so the patient has to start progesterone. In order to do that, they usually start that progesterone injection, and this is a very critical part, the day of the egg retrieval. If they don't do that, then their endogenous progesterone in an IVF cycle, remember, this patient was on a GnRH agonist up until the day of her HCG trigger. She was taking these medications up until the day of her trigger. So her endogenous production of progesterone and estradiol, of progesterone, are blunted. She will still make some because she has multiple follicles, and you go in and disrupt those follicles surgically. They will still have some response to LH and will make some progesterone, but it's going to be highly variable and it's going to drop off significantly. So they need the supplementation. This is a critical point. So if, for example, if I were to take a normal patient and plot out their progesterone after ovulation to 2 weeks later, it would look something like this. And then if they have a period, then if the progesterone drops, they'll have a period. Someone who's on doing this protocol, their endogenous progesterone after the trigger shot is going to go like this. So it's going to drop off very quickly. And if it drops off quickly, and they have no exogenous progesterone supplemented, then the endometrium will not see enough progesterone to be prepared in order to accept the embryo when it's placed. So progesterone supplementation, can't stress this enough, is a critical component of implantation. So let's move on to success rates. So success rates at WashU for IVF, specifically IVF fresh cycles. So you're looking at success rates based on age down here at the bottom, and these are age groups based on federally mandated reporting. These aren't just arbitrary age groups. By law, we have to report success rates in these age groups. And what you see is success rates are pretty good. And then when you hit age 38, they start to decline. And I use that to tell people, hey, your fertility is pretty decent, but when you until you hit the age of 38, at which point you'll see the first major drop. So fertility, we tend to think it's pretty good. And then when you hit your 30s, it kind of plateaus a little bit. It's when you hit 37 that it starts its more rapid decline, not 35. So people think 35 is this magic number, but it's really after 37, 38 where you start to get this rapid decline. So I think that's important for people to understand, and that's manifested here. What you're looking at here, just again, the bar graphs are 2015 data, and then 2011 to 2015 data, and then this is national average in gray. So you can see here at WashU, we're pretty good at what we do. So how much does IVF cost? So this is always important because IVF is physically, emotionally taxing, but it's also financially taxing. So it's important. We make a lot of decisions, and patients make a lot of decisions based on cost. So if you look, I mean, a fertility physician has to be by nature cost sensitive. So for example, and again, that hinges on what market you practice in, because if you are practicing in a state in which there is a comprehensive fertility mandate, like in the state of Illinois, like in Rhode Island, Connecticut, Massachusetts, then you actually, insurance companies, many of your patients are very likely to have coverage up to 4 cycles. There are 4 states that have comprehensive mandates that I just described, where they'll cover 4 IVF cycles, and then an additional 2 if you do have a live birth. There are 15 states that provide any kind of fertility benefit, many of which are not comprehensive and very rudimentary. So it's important to know that, here in Missouri, for example, Missouri is a non-mandated state, but we border a mandated state. So we get a large volume of patients from out in the state of Illinois. Now, there are also employers, private employers in the, in the city and the metro area that do provide a benefit to their employees. All the benefits vary. Wells Fargo, BJC WashU provides $10,000 max lifetime towards fertility treatment. Wells Fargo, $35,000 max. Monsanto, I think, is $35,000 to $50,000. Some places will cover 2 cycles. They won't have a max cost out of pocket. They'll just cover cycles. But if you don't have coverage, which is most patients, we'll say 50-50 in our practice. Some clinics, it's 100% do not have coverage, or very few have coverage. But if you don't have coverage, the cost of IVF is $11,437, plus the cost of the medications, which are ordered and billed separately. Now, these are typically the specialty medications, recombinant FSH, human menopausal gonadotropins, the Lupron. Those drugs are expensive, and they add up. Obviously, someone who has a high AMH level is going to need less drug, $3,000 worth of drug, as opposed to someone who has a low AMH level, who might need a more aggressive stimulation. Genetic testing we talked about is anywhere from $3,000 to $7,000. Pre-implantation genetic testing for aneuploidy is about $3,000 to $3,500, and then pre-implantation genetic testing for structural rearrangements or mutations, you're looking closer to $7,000. And again, insurance typically will not cover pre-implantation genetic testing for aneuploidy screening, even if that same insurance policy covers IVF. And that's a statement right there on, if the insurance company doesn't cover it, there's a big statement about the controversy in and of itself. And then I thought this was an interesting footnote. In 1994, in one of the first papers published in the New England Journal looking at the cost of IVF, when they surveyed the clinics, the cost of IVF was about the same, $9,000 to $15,000. So I don't know if that's a commentary on inflation or not, but I think it's important for people to have a frame of reference. So that ends the conversation on the assisted reproductive technologies. Again, we talked about IVF, fresh IVF. We talked about how it works. It basically builds on the principles of manipulating and amplifying the menstrual cycle. We talked about the frozen embryo transfer cycle in and of itself. We talked about pre-implantation genetic testing, success rates, cost,